To many of you in the room, our next speaker will not need any introduction because I'm sure many of you know him very well. He spent 7 years in Oxford as the Director and Professor of Evidence-Based Medicine, and now is a recipient of an MRC National Award in Australia. And just like Victor, he works as a general practitioner and a practicing clinician. One thing just before he starts, could you all squeeze in a bit, because unlike most conferences, there's still a lot of you here and want to get in, so if you could just squeeze to the middle. So as you sit there, I'd like to introduce, and he's going to talk about research to evidence implementation, Professor Paul Glasziou.
Thanks very much, Carl. So I'm the warm down act from Victor Montori. I've now retired, as Carl said, to Australia. I write a few papers in between surfing and when the weather's not too good, which is very occasionally. But it's a pleasure to actually come back to the UK and talk about some of the experiences I had in my time in Oxford. I'm going to focus on some of the work we've done in general practice, but talk about some experiences I've had in talking to others about evidence-based medicine. And in particular, I want to focus on this thing here that we've focused a lot in the last couple of decades on the evidence. And these forest plots, I'm sure, are very familiar to people, and the sort of summary of, yes, this looks like an effective therapy. But we're focused less on the what is it that we actually do. And I particularly want to talk about that because I think it's an essential part of the translation into practice. And I didn't put up the slide that Victor started with about the pipeline, but in a sense these two talks fit together very well because Victor was talking about the patient part of that, about them being persuaded to do this, but also the what to do and the time that takes. There's a lot of detail to that. But I'm going to talk about the two earlier stages for the clinician being persuaded by the evidence and also the how-to part of it. Okay. So let me begin by describing the problem. I did my training in general practice while I was in Australia. So I did my fellowship there. And I remember just before I went to the exams, my training advisor, Wendy Francis, said to the group of us who'd been her cohort, she said, "You know more now than you'll ever know leading up to the exam." That made me feel terrible. I thought, I don't know much at the moment. If my patient, this is the best I'm going to be, my patients are in real trouble. So I thought there's an interesting concept that she felt that the sort of exam time, the swatting that you'd done to prepare for the exam was actually the most you'd ever know. And I hope that's not true. And I want to talk to you though about some of the problems in doing that. So that's Francis's peak. So let's assume she was right, that I was up to date at the time I actually did the exam. Well, and that might be fairly recently, so you should get one of these t-shirts that says, "To save time, just assume I know everything." But you need to put a date on the t-shirt as well. It's very important. You might have known everything in 2009, but things have actually changed. I'm going to give you some idea of the degree of that change before we move on to look at how different specialties might cope with that change. First of all, it's just the number of diseases. So there's a lot of terms in medicine. The National Library of Medicine's Metathesaurus has nearly 1 million terms in it. We don't know the number of diseases exactly, but Diagnosis Pro, which is a free expert system that you can type in some symptoms to and try and find out diagnoses, says they diagnose about 13,000 conditions, 13,000 diseases. Okay, if you were going to be very careful and study one new disease every day, it would take you about 40 years to get through all the diseases. It's quite tough for a medical student to do since they don't have a 40-year course at the moment. However, by the time you'd finished, you'd actually be out of date still because of the number of new diseases that are coming along. We've been doing some work to try and estimate how many of those disease descriptions are recent, and probably half of them occurred in the last century. So there's been a rapid increase in the number of diseases we know about. And there's an interesting place called OrphaNet, which talks about all sorts of orphan drugs and rare diseases. They particularly focus on this thing of rare diseases, and they say that there are 6,000 to 7,000 rare diseases in their database, but they're adding approximately 5 new diseases every week. So if you programs for each disease, I think you've got to use 5 new programs every week. And my microphone, it's my turning, isn't it? Okay. Another issue is, even if you knew all about those diseases, you could keep up to date with them. Actually, our knowledge, for example, about the effective treatments of those diseases changes. And there was a really interesting study in the Annals of Internal Medicine a couple of years ago where they looked at 100 systematic reviews that had been updated recently, and then they looked further down the track. They took the cohort of those reviews and redid the reviews to say how soon after that review had been published would it have been out of date. And their answer was a median of 5.5 years before a signal to change would have occurred. And interestingly, you see in the top of this little survival plot here, there's an immediate drop. In fact, 7 of the systematic reviews were out of date the day that they published. Because if you look at the search date and the time it takes to get a publication in, actually new trials can come along in the meantime. And what they were talking about here wasn't just the presence of a new trial, because that may not change conclusions. They were saying these were things that would actually change, for example, the statistical significance or the estimate of effect by more than 50%, or make some other qualitative difference about the harms that we know about, etc. Something that would make a difference to clinical decision making. So it's not just the presence of a new study, this is actually a change in how we'd use this information in practice. So things are changing and we need to cope with that. So if we think about the advances of medicine, there are 2 aspects that I show in this. This is 2009. In the change to 2010, we'll have an expansion of knowledge because of the number of diseases, the number of new chemical entities, etc. And then amongst that, we have this problem that some of those will just be fashionable changes, things that will come and go, and some of them will be real advances in medicine. And one of the problems we have is knowing which is which of those 2. But whichever we do, we've got to realise that medicine is actually changing. It changes at such a modest sort of pace that we don't actually notice the annual change. But if you think what medicine was like 40 years ago, it's revolutionised in the period of someone's clinical lifetime, and you need to keep up to date with it. Okay. And that's the way we all feel about this, I think, with the 2009 knowledge being this in the middle here. And we need to pick out of that large number of journals the ones that are actually going to change our practice. So I'm going to look at that from 3 different disciplines. I'm going to focus mostly on primary care because that's my discipline. But I've been doing some podcasts recently by interviewing people in evidence-based medicine in different disciplines, different specialties. And it's been a fascinating exercise to do. I've learnt how different evidence-based medicine looks depending upon the specialty that you're in. And it's very different in the narrow specialty that has very few topics that you need to keep up to date with compared with the generalist specialties where you've got a vast field like in internal medicine or in general practice. It also depends on the culture of those specialties for trials and systematic reviews. That makes a big difference within each of those specialties as well. So the attempt to practice it actually looks different. And the 3 that I'm going to talk about, there are about 8 of these on the website at the moment, if you go to the Centre for Evidence-Based Medicine website. Bob Phillips looking at oncology in Leeds, he's a paediatric oncologist. Richard Nicol, who's a neonatologist in London. And I'll look at my own practice that was here in Oxford. Okay, so evidence-based childhood cancer. This was one of the extremes to me. So Bob said that 90% of the treatments that he was giving were based on trials. About 50% were based on kids currently being randomised into trials. Some of the kids, though, the trials were actually closed, and what they were using was the best treatment out of the protocol. So the protocol may have randomised people to A and B. That trial had now closed. B was the better one, and so that's what they were now using for that particular treatment. So to a GP who rarely enrolls a patient in a trial, to have at least 50% being based on trials, enrolled in trials, was just amazing. The remainder, though, is a long tail of rare cases. For example, he was citing to me the case of a kid with pancreatoblastoma, and there had been 44 cases in the UK. So if you'd tried to do the trial and your target number was 100, you still would not have achieved the first test of any therapy. So he actually wrote to someone in the cancer registry here who put him on to someone in New Zealand who told him about the case experience in trying to treat that particular condition. One interesting thing I'll point out, because I'm going to come back to this about the whether to and the how to, is that the whether to do this, the decision part of it, is based on the trials and the results of the previous trials or the current protocols. But the protocols also specify the how to component, what dose I'm going to give, what sort of monitoring I'm going to do. So a nice description of the intervention is actually built into the protocol. So this is less of a problem then for paediatric oncology. They are somewhat unusual. I can't imagine many people who actually have 50% of their patients enrolled in randomised trials, but it's not unusual in paediatric oncology. These are the figures in the UK for the enrolments in trials for a number of conditions of the common cancers, and you can see for kids up to about 14 here, it's around 50 to 60% being enrolled in trials and much less in adults. But even the adult figures here, for me working in general practice, are extremely high. Okay, what about evidence-based neonatology? Okay, this looks a bit different. There's a broader range of things, fewer of the kids actually enrolled in clinical trials, but it's an area where the Cochrane collaboration, in fact the predecessor to the Cochrane collaboration, had been doing the systematic reviews for a long time. So this is a group, the Cochrane Neonatal Group, where a large number of the reviews have actually been done. There's 342 reviews there, and they're kept up to date fairly well. So you may not have kids in trials, but you can base a lot of your practice on what's known from the systematic reviews, unlike general practice. So Richard Nichols, an enthusiast for EBM, and you can listen to his description on the Centre website, and he says what he does is that they don't actually try and answer questions during the ward rounds, but they keep a record of the questions. So they write them down and say, well, we need to go and look that up after the ward round. Sometimes they look them up immediately, and sometimes they allocate them for the journal club if it's a thing that's come up several times or seems particularly important. And they keep a folder of critically appraised topics of questions that they'd previously answered as well. And email that around the group for people who might have missed that particular session. And just to give you one example of the sort of thing, they had an outbreak of infections in the group, and they decided they need to do something about it. But rather than taking the typical reaction of, well, here's a problem, here's something to do, let's do it, they said, let's review the evidence first of all. And there was some interesting evidence in the area. For example, should you wear gowns? Well, it's a Cochrane review that suggests that gowns actually have no effect on unless you're actually doing a procedure, but routine use of gowns going into the neonatal unit has no effect. So they found the evidence, but they also found evidence about implementation. So in particular, they found a unit in Geneva that had been working on ways of reducing infection based on what we know from clinical trials, but also looking at how do you actually put that into practice. And they managed to do that. And I've put up a poster here that's actually in the entrance to the neonatal unit, and you can tell it's an NHS ward actually, can't you, because of the yellowing paint and the hole in the wall here. Dead giveaways. But it's an interesting poster. It's not the only thing that they did though, but this poster is very helpful because it doesn't just say wash your hands. It actually breaks it down. It says, are you a parent or relative, a doctor, a nurse, a therapist, a radiographer or pharmacist, clerical secretary, laundry, etc. So what's your role in coming into the unit? What should you do the first time you come in? How should you do it? Specifies that, all in very brief language, and then what should you do on a return visit as well. So it's a much more specific how to do the process, the details of the implementation. So that was one vital part, but they also had team meetings to discuss what particular approaches they were going to do to take this problem, etc. So it wasn't just this review of the evidence in the poster. Okay. So there were two quite different views for me. One is the one of the paediatric oncology being trials-based, the neonatal unit largely being able to use Cochrane reviews, but also some other evidence as well. And I found those quite interesting and different from what I'd experienced in general practice, where there's just such a large number of conditions. And typically in general practice, we'd suggest for evidence-based practice that you keep a logbook of questions. So I used to keep a little paper one, I now do it electronically. And very importantly, you need to have team meetings about this. So we had a fortnightly journal club where we discussed the things that were in our logbooks or that were in the EBM journal, or perhaps a recent guideline as well. A variety of things we discussed. And one of the difficulties, of course, is the variety of things that we face. This is some data that I've derived from the Birmingham Research Unit on what we see in general practice. If you look at the frequency of conditions seen by the type of condition, You get up to about 30 here to get 50% of the consultations. But the remainder of the consultations take another 770 different conditions, so there's a very long tail. This is a much flatter distribution than you would get in paediatric oncology or that you get in neonatal intensive care, where you can take care of a lot of the conditions with just a few areas. Now, of course, there are many problems within those. If you compare it with endocrinology, for example, endocrinology is mostly diabetes and a few other rare things. So they've got one condition that takes care of about 80% of their problems. But of course, within that, there's a whole series of questions and problems in taking care of diabetic patients. Okay, so one thing we recognise is we can't cover everything, but we should cover the core topics. If this is something that we know is one of those conditions and it's a change in the practice in that area, that's a signal that we probably need to look at this in a journal club, the sort of just-in-case learning. But you get a lot of just-in-time learning. I recognise there are 13,000 diseases. I'll never see them all, but I'm going to have to treat all the ones that my patients have, and I can't predict what that's going to be. So some of those things I'm going to have to learn about at the time the patient walks in the door. And I'll give you illustrations of both of these. What I thought I'd do is walk you through a sort of morning clinic. We don't have time for the full clinic, so I've just selected out 4 patients from that particular morning and talk you through some of the ways of getting the evidence, but also the details of actually implementing that evidence, which is my concern today. So we've got 2 of the common conditions here. Blood pressure, we're going to have a routine visit for hypertension. Somebody with chronic obstructive pulmonary disease, and I'll explain this thing in a moment. A slightly rarer, somebody with benign positional vertigo, and somebody with Raynaud's phenomena. So 2 common, 2 rare conditions, and that's typical of a morning practice, that a lot of it will be the common conditions, some of it will be rare ones. So let's go to the blood pressure one first of all. Most patients that I see are interested in lifestyle changes. They don't want to take the tablets, and one of the things I'll ask about is what things can I do in order not to take the tablets. And there are a few suggestions that we know you can make there, like weight loss, etc. And one of the routine ones is salt reduction. And in fact, there had always been some doubt about that until a trial was published in the British Medical Journal a few years ago, the THP study, which was the first long-term follow-up of salt reduction, showing that it decreased outcomes. So we knew that if you could get salt reduction to work, you could decrease blood pressure, but we didn't know whether it actually influenced clinical outcomes or not, whether it lowered stroke and heart attack and all the nasty things we wanted the patients to avoid. Now we had evidence of it. The question is, what do I actually say to the patient on Monday morning who comes in for their blood pressure check? And you'll notice here, by the way, that our clinic nurse is using the guidelines to measure blood pressure in both arms. I wonder how many people here actually ever do that. So here's the TOHP study. The paper's description of sodium reduction was individual and weekly group counselling sessions were offered initially with less intensive counselling and support thereafter, specific to sodium reduction. So I want you to imagine, what does that actually entail? You're going to tell the patient to reduce their salt on Monday morning when you see them. What's that actually going to entail? What specifically would you tell them? We can't really tell from this paper, but if you track back to one of their earlier references from about 10 years previously, they do give a fuller description of what they said to the patient. And that is, 1, an individual session for 10 weekly group meetings of 90 minutes with a nutritionist, followed by a transitional stage of some additional sessions. Topics in the weekly sessions included getting started, the sodium basics, the morning meal, midday sources of sodium, the main meal, planning ahead, creative cooking, eating out, food cues and social support. The sessions included sampling of foods, discussion of articles on sodium reduction and problem solving, and patients kept diaries at least 6 days a week, and urine sodiums were measured. Did anybody imagine all of those things when they read the first description of that intervention? And even this, when you read this, most people's reaction, if they're a general practitioner, is, this is off the planet. There's no way you're going to do this intervention with a patient, even if you can get the resources to do it. But even this isn't sufficient. It isn't a sufficient description to replicate what they did here. It tells you that there are lots of missing details, but I'd actually need to have the booklets. I'd need to know what they did in these sessions. It just tells you that there's a lot more to know. I'd like copies of the diaries, etc. So again, I can't actually replicate this. Okay, so this actually got us interested in how often was this a problem because I'd come across it as the editor of the EBM journal, that quite often I couldn't quite get a solid idea of what the intervention looked like. So we went back through the EBM journal and looked at 80 specific treatments and asked, were the descriptions sufficient to replicate the intervention? So Carl Hennigan and I, the two GPs, just said, could we replicate this on Monday morning when the patient came in? And our finding overall was about 50% of these we thought were replicable. We could do them in practice. And it was better for trials than it was for meta-analyses. It was better for drugs than it was for non-drug therapies. But it was a problem across the board. There was some degree of problem there. Then what we did is that Emma Meeks, who was the research assistant, wrote to the authors. We searched the internet. We searched back through the references. We tried everything we could to track down the details of the intervention so that we might be able to describe them more fully so that we could replicate them. And after we did that, there was an improvement. About 1 in 4 we could now replicate. For a small amount of work, this probably took about half a day to a day's work to get this extra information that would make a 1 in 4 difference. It's the most cost-effective thing, in fact, I can think of in healthcare, would be to get these extra descriptions, because the amount of work to do it is so small compared with the overall cost of a trial. So if you remember Ian Chalmers' talk yesterday about the avoidable waste, this is probably the cheapest solution to one of the elements of waste that we could come across. Okay. I'm going to give you another example of that. That was a specific trial. And sorry, I should say with the since we're in the BMJ, but despite that trial being published in the BMJ, they've actually been very on-site and very helpful about trying to solve this problem and are interested in working on it with various creative solutions to that problem. Chronic obstructive pulmonary disease. So I had this chap come in, had chronic obstructive airways disease. He didn't like medications. And he said, were there any breathing exercises I could recommend? I scratched my head and I said, well, actually, I remember seeing a trial in the BMJ again about didgeridoos. And he asked me the very sensible question. He said, well, can you prescribe a didgeridoo on the NHS? I didn't even bother looking up the BNF. I was pretty sure I couldn't get them. They'd probably be too expensive. I don't know if there's been a nice review of the cost effectiveness of didgeridoos, is there? Anyone know? But actually, what I realised that he was, when I sort of dug deeper into what he was really on about, was he wasn't specifically interested in breathing exercises. He was actually interested in non-drug interventions. He didn't want to take tablets and pills, and he wondered if there was any sort of natural remedy, if you like, that could make him better. So I had a look around and I discovered, I'd heard about but didn't know the details of pulmonary rehabilitation. And this is the little bit from the NICE guideline about pulmonary rehabilitation, which they said was very effective and should be used in chronic obstructive airways disease. It says pulmonary rehabilitation is defined as a multidisciplinary program of care for patients with chronic respiratory impairment that is individually tailored and designed to optimise the individual's physical and social performance and autonomy. Therefore, there's this high recommendation with A-level evidence. This is the entire description of pulmonary rehabilitation. So what do I do on Monday morning? I suppose I could refer them, that would be one, but it's actually difficult to get them referred because there's a limitation on the number, so I wondered if there was anything in between that I could do. It's pretty convincing evidence that it works. This is the forest plot from the Cochrane Systematic Review. You can see it favours the pulmonary rehabilitation. This is for hospital admissions. There's a 90% reduction in hospital admissions. No drug does that. Here's an alternative therapy that this guy was interested in that might actually do this. The Cochrane Review, I must say, is actually quite good on this. It has pretty clear descriptions, though very brief, of what the different interventions entail, and it actually looks different in every one of the studies. The common thing seems to actually be the exercise component, but there's all sorts of other things about patient education, counselling by a psychologist, etc., social groups, but in different styles in all of the different interventions. So still, this is helpful, but still didn't give me exact details, and it was actually discovering this on YouTube that actually helped me really understand what pulmonary rehabilitation was about. So the Kings, who actually put up a couple of videos, a two-part video that takes you through what pulmonary rehabilitation is about, and I highly commend going to them. This woman here is a quote from her. She said, "I didn't know what it was, so I asked, and he said it was an exercise program. I thought the man was mad because I couldn't get out of a chair." And then you see it, they interview her a couple of months later, she's actually now able to get out of the chair and walk around, etc. And I mean, to me, the fundamental of pulmonary rehabilitation is actually that people who are sick can get fitter. Just like any of us can get fitter, if you get somebody to exercise for a long enough time, they can get fitter too and they can do more activities. But you have to support them in that, because you're not going to get fit in a week or 2 weeks or 6 weeks. It's actually going to take you some time to do that. You've got to have an exercise program and be helped through that. And that's what the other penumbra of things around pulmonary rehabilitation seem to be. Okay, let's move on to they're the common cases. Let me move on to a couple of rarer cases. I remember a patient coming in who had cracked and blistered painful hands because they were a rower. So they had severe Raynaud's. They get very cold hands for a long period afterwards, and it was causing a dermatitis from this. And she said, well, what can you do about it? And I said, well, I'm from Australia. We never see this. So my first thought was to use Yellen's bluff. This is a technique taught to me by my supervisor when I was doing my GP training, and he said, if you don't know anything, what you do is you send the patient out for a test of their urine, and while they're out there, you can look up stuff. I occasionally use that still, but I didn't actually in this case. I actually admitted to her that I didn't know. I just said, well, I'm from Australia. I really don't know how to treat this condition. I never see it in Queensland. I just wanted, before I go on to the answer that I actually found, I just wanted to give you a little warning about the dangers of looking stuff up, though. That this is a skill that we need good resources and you need training in this to do it reliably. This is some work by Anne McKibben, who at McMaster was a part of her PhD, and she got docs. These were internists or general practitioners to answer a question. Then they could use any resources they liked, online or paper, to look up the answer to the question, and then they could answer the question again. And here's what she found. 28% of them went from right to right, that is, they didn't change their answer. 13% went from wrong to right. Great, they improved their answers. Worrying low, 11% went from right to wrong. That is, if you do your standard Google search and find that first piece of information, it may mislead you. You already knew it was right, but you've actually been misled by the answer. And then 48% went from wrong to wrong. Some other studies on this, though. A system called Quick Clinical, developed at the University of New South Wales by Enrico Coira, is based on Brian Haynes' 4S concept of a sort of layered strategy to getting evidence out. And here, these were GPs again, 21% right to right, 32% going from wrong to right, that's improved, but 7% still going from right to wrong and 40% unchanged. At least here there's a gain. Okay, so there's a substantial gain between these, but this is still a deficit. The system's improving the searching. So these again were untrained people. They weren't trained in any searching techniques. They were given I think 5 or 10 minutes training in the interface and then asked to answer these questions. And the original studies were done by Hirsch in medical students and nursing students, and they actually improved, perhaps because they were pretty ignorant to begin with anyway. I didn't know the answers. So what I did in this case was just looked up the therapeutic guidelines. This is an electronic guideline system from Australia. The options were, actually it was a series of antihypertensives, and that worried me because her blood pressure was about 105 on 60, and I thought she's going to fall over if I give her any antihypertensives. But the other thing was glycerol trinitrate ointment, right, which we use for angina. I thought, oh, that's interesting, I've never heard of that. But it didn't have the evidence for it. So what I suggested to her was to try it on one hand first and see if it made any difference. So I had a control hand because I wanted to gather the evidence to make sure this worked. And about a week later she rang up and said, can I start using it on the other hand? It's great. So it was my N of 1 trial. One of the useful things about this particular set of guidelines, unlike the thing I showed for pulmonary rehabilitation, is it actually gives the specific details. So it gives the dosing here, the glycerol trinitrate, the amount that you've got to give and how you apply it, etc. So those useful details seem to be pretty uncommon in guidelines, but they're actually essential if a clinician is going to tell a patient exactly what to do. And just before I left that, I thought it's useful just to mention the idea that in general practice there are often things where there isn't much evidence, or that we need to glean it ourselves to see if it works in this patient, and one possibility is doing N of 1 trials, treat one hand, I sometimes treat one eye, patch test for rashes, or treat one side for a rash, and sometimes I've used week on, week off for things as well. Okay, end of the morning clinic, it's our last patient. Phew, this is one I know about. Frequent episodes of dizziness triggered by changes of posture, and medication that they've been on hasn't helped. So this is benign positional vertigo, which I demonstrated. Does anyone recognise what this thing is, by the way? Okay, no, it's called a dizzy fix. It's for doing the so-called Epley manoeuvre, which I'm just about to tell you about, and you get this little bubble to go through here. It's just a way of training patients in the Epley manoeuvre. Pretty neat little device, but I don't think there are trials of it. But there are several trials of the Epley manoeuvre, so the standard treatment for this, which is one of the commonest causes, or probably the commonest cause of vertigo, this benign positional vertigo, now has a pretty good treatment. It was invented about 30 years ago, but it still hasn't diffused well. A lot of people have now heard of it. Most people still don't actually do it though. The Cochrane review is actually exceptional in that it actually gives this illustration in an appendix to the systematic review, which gives you the treatment details, which is pretty rare for systematic reviews to do. So I applaud the authors to for actually giving such detailed descriptions. In fact, the one that I actually use with patients is this patient handout version, where you can train the patients to do it on themselves, and it's got a left and a right hand version depending upon which ear it's in. In my practice, we went through the evidence for this. We all said it was useful, and then nobody did it because they didn't feel confident in doing it. It actually took months of trying different things before what I did was I went around and trained everybody in the practice how to do this procedure and got them to practice on me so that they'd stop referring the patients to me, because I didn't know how to do it either. So that was an interesting procedure in itself. Everybody was persuaded. The evidence here was fine. It was actually learning the how-to of the procedure which people found difficult. Anyway, a couple of years after this, we had Martin Burton, who's the local ENT consultant, into a session, and we were talking about lots of things. And this is a very useful thing to do. We asked him questions. And one of the issues raised was the Epley manoeuvre. And when we were discussing it, one of the GPs in my practice said, well, what they do now, which is a really interesting idea, is they bookmark one of the YouTube videos that shows you how to do the Epley manoeuvre. And she gets it up. She can never remember how to do it. So what she does is she gets up the YouTube video and says to the patient, I'm just going to show you what I'm going to do. And then they go through it together to have a look. And she's actually reminding herself, but it actually serves two functions, because the patient then sees what they're supposed to be doing as she's going through it, but she's also reminding herself how to actually do the manoeuvre. So it's interesting, these little bits of sort of tacit knowledge that are in addition to the standard descriptions that we hear in the publications that are actually useful in implementing things in practice. And one of the things that Carl and I have been working on was a repository to keep all of these intervention descriptions. I'd said what we need is a non-pharmacopoeia, and Carl said, no, that's not a very good term for it. And he invented the acronym for this called HANDI, the Handbook of Non-Drug Interventions, which is probably going to be much more saleable than a non-pharmacopoeia. So, evidence-based general practice. It is possible to do it, but the evidence is a lot more scattered. We have few patients in trials. Often the systematic reviews aren't there to inform us in general practice. The evidence quality, because of the number of conditions we deal with, is much broader. And one of the problems is, particularly for using non-drug interventions, but it's true for some drug interventions as well, is often the how-to component is missing, as we saw in the salt reduction and the chronic obstructive airways disease components cases. And that's a general truism. It seems that as we go up the Brian Haynes's 5S hierarchy, that we lose information. There's a loss of treatment details as we go up from the single study to the systematic review to summaries, synopses or systems. That's not a necessary loss, but it seems to happen. You can't gain information on the way, you really can only lose it. And so that generally happens. We've documented that, as we showed earlier, for the studies in the systematic reviews, but it seems to me to be true of synopses and systems as well. The one I put down the bottom here is the ongoing trial protocol as well, because in fact for many of the things, because the single studies, the published studies, don't contain the details we need, it would be nice to have access to the protocols, which often do have the additional details you need, though not always. Some of them are in additional booklets, etc. And just going back to the three specialties that I chose to talk about, paediatric oncology, of course, has direct access to these protocols. That's what they're basing their treatments on, so they don't suffer this problem at all, or minimally so. Whereas in neonatology, they're using systematic reviews and single studies sometimes, so it is something of a problem for them, and it's probably more of a problem for general practice because of the breadth of things that we look at and that we're using all layers of Brian Haynes' 5S hierarchy. So thank you very much for your attention.
Thanks, Paul. I have a request on Twitter from John Barassi, who runs excellent Twitter. He wants you to make available the 30 conditions, if possible, so that they're wondering which are the top 30 conditions.
Oh, sure. Yep, I'll be happy to send you the list that I got. It's from publicly available data from the Birmingham Research Unit that's actually online. All I did was sort it, but I'd be happy to send anyone the slide. And John, I'll make a note to send it to you.
There he is. Okay. Great. Any questions then for Paul? Here you go, down here.
Your supervisor told you peaked, and your supervisor told you that you peaked on your factual knowledge when you wrote your exams. I'm assuming you're a better GP now than you were when you began. Mm-hmm. And I suspect that you've learned things that are not evidence-based that make you a better GP. If you agree, what are some of those things?
That's an interesting... So I've learnt lots of things that are evidence-based as well, by the way. So because I edited the Journal of Evidence-Based Medicine for a long time, that was one of the ways that I keep up to date. But I think there are lots of things that I've learnt, partly directly from my patients and partly from other GPs are probably the two sources. This is a long conversation, but let me give you two examples of things I think I've learned. One is very close to Victor's, of giving the patient control. So I had one of his diabetic type patients come in once who, when I told him, I diagnosed him as diabetic, and his blood glucose was, I've forgotten, 33 or something, pretty dangerously high, and I said, I think we've got to send you into hospital. And he said, Doc, I would rather die than ever go back to hospital. He'd had such bad experiences in hospital, he refused to go back. And I could see this is a big Maori guy, you know, he'd kill me if I said too much to him. And what I said is, look, you're in control, you're the decision maker. I'm just going to give you some advice, I'm going to tell you about the options, but actually it's all and you could see him relax. And that was a real learning for me to just make that explicit, that it was his choices he was making, and I was just there as his advisor, his informant. So I think that's one key thing I've learned. The other one, harking back to my thing about the Epley manoeuvre, is that often learning the how-to components of these things, there's lots of little variants that you need to learn. So there's a sort of basic Epley manoeuvre, but I didn't know about the contraindications, I didn't know about the YouTube videos, the handouts, and I learnt all of those from other people, not necessarily. I learned about the manoeuvre itself from the Cochrane Review, but there are all these bits of tacit knowledge that other practitioners had that I've gradually accumulated around that procedure over time.
Supplementary?
Supplementary, yeah. Okay. 30 seconds.
Yeah. My point is the following. Of course, you know, we give a lot of weight to what we can quantitate. But there are wonderful clinicians that we have a lot to learn from. Do you think this is one of the unexplored treasures to somehow systematize what many of these clinicians have learned on their own? And I would bet there's a lot of commonality in the great clinicians of all specialties and generalists.
Yes, yeah, no, I absolutely agree with you. And that's why, remember Victor put up that slide of evidence-based medicine, having the patient's values and preferences, clinical experience and the evidence. In a sense, evidence-based medicine isn't denying the value of those other two things. It's just saying we would like to add the evidence in, and I think it would be good to focus on capturing the clinical experience as well. And one of our ideas for the Handbook of Non-Drug Interventions is not just to describe it, but to have it as a sort of living document that people can add these rapid responses to and their own videos, their clips for suggestions, to collect some of that tacit knowledge as well. I think it's a great idea and an untapped source of knowledge.
Thank you.
Okay, we're going to draw to a close there. Anybody who wants Paul can grab him over coffee. So thanks, Paul.